There are a variety of definitions for a high-risk renal transplant patient that are related to immunologic risk. However, for the study that we presented results today, we attempted to define the high-risk population based upon their expression or their non-expression of an important enzyme that metabolizes tacrolimus, cytochrome P450 3A5. In the context of that, what we have found historically and what has bore out in our previous studies is the patient population that expresses this enzyme does have higher variability in their tacrolimus exposure. It just so happens that the patient population that we consider as high immunologic risk, African Americans, one of the patient populations, actually do express that protein or gene more frequently than do Caucasians, for example. So in our mind, it is a more strategic way of identifying what is the high-risk patient when we attempt to define factors that are going to impact the tacrolimus variability. The data that we presented today reflected that the non-controlled trough measurement is roughly only a 50 to 60% predictor of the overall AUC. However, it is impractical for us to measure area under the curve or AUC in a normal transplant population. Therefore, we rely heavily on trough level monitoring. There is variability that is seen, but there are other sources of variability, not just formulation. And in our more controlled studies, we were able to show that the percent variability for not only trough, but Cmax, Tmax, and area under the curve were not statistically different between the three formulations that we tested there, Prograf, Sandoz, or Dr. Reddy's. And essentially we see an within subject variability of roughly 12% or so with the AUCs when we've measured that. And again, it's no different when you give any of the formulations. I think that the majority of the variability is associated around the time you take the dose or within the first 4 hours. And we actually did present some data related to the variability in AUC between 0 to 4 versus 0 to 12, and there was a slight increase in variability at that time. While I don't know that it has been completely proven yet, it is not irrational to think that a product that would be taken twice a day, because there are two absorptive phases, would have an increased variability compared to one that would be taken once a day. No, not to date. I think that, as you are well aware, it takes a long time to see a significant change in even acute rejection rates and patient and graft survival when our outcome measures for those outcomes are relatively good. The event rate is low, so it would take a long time. I think it is important to know that there has been generic formulations occupying over 75% of the marketplace for at least 4 years now, and we have not seen at least dramatic reports of decreases in patient survival or graft survival or increase in acute rejection rates. The current barriers that we have are the endpoints that are established as standard, which are biopsy-proven acute rejection, patient and graft survival. We have become very successful in improving our one-year outcome measures based upon that composite endpoint. We need to develop either surrogate endpoints that will address some of these issues. Could it be tacrolimus level variability? It may very well be. However, we would have to test the outcome measure with the surrogate endpoint and then also continue longer term studies to show that it actually correlates with a long-term outcome. Essentially, the studies will be required to be so long and require so many patients to actually see those effects that they tend to be cost prohibitive. Long-term studies in the transplant population are going to require an extended period of time and also an increased number of patients. In addition to that fact, transplant patients have several comorbid conditions that basically tend to impact the long-term outcomes as well. So it's not just one individual immunosuppressive agents. There are a lot of other confounding factors. So therein lies another logistic issue that makes it even more difficult. I think that the AIDS community and the cancer community have outlined very well some alternative strategies for drug approval. I think that we as the transplant community have to devise the endpoints, test them, and then provide them to the FDA and let the FDA give their feedback to us. I think we're in a position now that we should ask. There are alternative endpoint strategies that are currently in process and in study, and I think that that speaks volumes to the direction that we're headed. And I encourage, new endpoints created that will be applicable to the future. Okay. Pharmacogenomics testing at the current state will reflect roughly 20 to 50% of the variability that we see. Right now, we can't predict the other, 50% variability. We are fortunate with tacrolimus that we do have levels to monitor. And essentially, within the early post-transplant period, as clinicians, as astute clinicians, you can ascertain if a patient is an expressor or a non-expressor. So yes, ideally it would be advantageous to have that information ahead of time so you could dose adjust appropriately and follow some of the CPIC guidelines and know when to increase the dose. However, when you do not have that information, when you are dosing a patient on tacrolimus and within 2 or 3 days they are not achieving the levels that you are expecting to achieve, you should really assume that they are an expressor and begin to attempt to overdose instead of underdose. It's my personal opinion that there's more risk to underdosing in the early post-transplant period and exposing the patient to rejection than actually overdosing them where we would have just an acute toxicity that we could treat.